Welcome to the Deep Dive. We're here to cut through the noise, get you truly well-informed. Today, we're plunging into a topic that, well, it touches us all. Public health. What's often overlooked, I think, is how the biggest health challenges aren't just about medicine. They're deeply intertwined with much broader societal factors.
That's so true. Public health often reflects the ultimate systems problem, really. And the sources you've shared with us today, they brilliantly illustrate that. Our deep dive is zeroing in on two significant public health challenges, specifically looking at their prevalence and control in India. We're talking rheumatic heart disease and various cancers.
Right. And our mission, as always, is to pull out the most important nuggets of knowledge from this stack of sources, give you a real shortcut to understanding these critical issues.
Yeah, think of it like your express lane to gaining genuine insight.
Exactly. Complete with, surprising facts and plenty of aha moments you can actually use.
And speaking of surprising, let's maybe kick off with this.
Yeah.
Did you know that rheumatic heart disease, or RHD, well, it's the commonest heart disease in a really crucial age group like 5 to 30 years.
Mm-hmm.
And yet, at the same time, it's one of the most readily preventable chronic diseases out there.
That statistic is, wow, really eye-opening, especially when you contrast it, like you said, with the staggering scale of cancer in India. Over 70% of cases reported in advanced stages that severely impacts survival rates. It immediately highlights two very different battles, doesn't it?
It certainly does.
Let's unpack them. So let's start with rheumatic heart disease. You called it the preventable heart challenge. It's a fascinating case because its origins seem, well, deceptively simple. Strep throat.
That's exactly right. RHD is a long-term consequence of rheumatic fever. And rheumatic fever itself stems from an untreated infection with group A streptococcal pharyngitis, what most of us just call strep throat.
Right.
It's essentially a cascading chain reaction where one untreated infection can end up leading to serious heart damage down the line.
And when we look at how RHD impacts populations, the numbers really highlight its significance. You said the most common heart disease in that 5 to 30-year age group.
Mm-hmm.
And while the initial rheumatic fever attack usually happens young, between 5 and 15 years, it can still hit adults about 20% of cases, right?
That's right. And what's particularly striking from the sources is that while rheumatic fever itself affects both sexes pretty equally,
Okay.
the prognosis for actually developing RHD is unfortunately worse for females. And this isn't just biological, It often points to societal factors, maybe delayed access to care, or different health-seeking behaviors that might influence how and when women show up with symptoms.
That makes sense.
The underlying mechanism, well, it involves the body's immune system kind of mistakenly attacking its own tissues because they look a bit similar antigenically to the strep bacteria. That's what triggers the rheumatic fever attack.
Okay, here's where it gets really interesting, and you touched on this, the profound socioeconomic connection. Our sources flat out call RHD a social disease. What does that truly mean for how we should think about tackling it?
It's a critical distinction, really. The sources emphasize this strong link to poverty, overcrowding, poor housing, inadequate health services, and just low community awareness. If you connect it to the bigger picture, RHD declines sharply, consistently with improved living standards.
Wow.
So that tells us that environmental factors and health system determinants are huge drivers of how strep throat spread so rapidly in the first place. High-risk groups, school-age kids, slum dwellers, people in closed communities like barracks, they're basically living in conditions ripe for these infections.
So if it's fundamentally a social disease, does that mean traditional medical interventions are almost secondary to fixing the bigger societal issues? How do you balance that?
Well, it's not exactly secondary, but it does profoundly shift the focus. The sources highlight that for rheumatic fever itself, secondary prevention is often the more practical route.
Okay, what does that involve?
It means focusing on promptly treating existing cases of strep throat or rheumatic fever to prevent progression to RHD, rather than trying to, say, medically treat every single sore throat in a whole community that's already battling these tough social determinants. It's about breaking that chain reaction at the earliest possible feasible point.
Right, that makes sense. And for those who, unfortunately, despite these efforts, do develop RHD, what's the intervention then?
So that falls under tertiary prevention. This usually involves symptomatic treatment and often life-saving valve replacement surgery. And crucially, after surgery, long-term penicillin therapy is needed to prevent more rheumatic fever attacks that could damage the heart further.
Oh, okay.
But the overarching point, the big takeaway here is that effective, swift management of acute rheumatic fever is the single most crucial step. It's about preventing RHD from even developing at all.
That's a really powerful message of prevention. Okay, let's shift gears now to another huge public health challenge, one that, in many ways, presents a different kind of battle. Cancer in India. The sheer scale is just, it's hard to grasp.
It truly is. Our sources estimate somewhere between 700,000 and 900,000 new cancer cases every year, and maybe 2.5 to nearly 4 million existing cases at any given time. In 2020 alone, there were over 1.3 million new cases and more than 850,000 deaths. Cancer is, well, it's unequivocally one of the top 10 leading causes of death in India.
And the most concerning fact, the thing that makes these numbers so stark, is that over 70% of these cases are reported in advanced stages, which, as you can imagine, leads to really poor survival rates. It's not just a statistic. It represents so many missed opportunities for earlier, more effective treatment.
Absolutely. And a major driver of this huge burden, according to the sources we looked at, is tobacco. Tobacco-related cancers account for about half of all cancers among men, and a significant 20% among women in India. This adds up to about 1 million tobacco-related deaths annually. It's not just a risk factor. It's a profound population-level health crisis.
Given those staggering numbers, what are the most common types of cancer that are emerging across the country?
Okay, so for males, the most common sites are the oral cavity, lungs, esophagus, stomach, and colorectal. And as we just discussed, most of these have a really strong link back to tobacco use.
Right.
For females, the picture shifts slightly. It's breast, cervix, oral cavity, ovary, and colorectal.
And are there any specific trends in women's cancers that are particularly worth noting? Breast cancer often gets a lot of attention globally. Is that the case in India as well?
Absolutely, yes. And the trends are quite telling. Breast cancer is proportionally increasing, especially in metropolitan areas. This is often linked to changing lifestyle factors, later marriage, having the first child later, fewer children overall, shorter breastfeeding periods, those kinds of shifts. What's really critical to understand is that cervical and breast cancers together, they account for more than 36% of all cancer incidences in India, and nearly 60% of all cancers among Indian women. In fact, breast cancer has now actually surpassed cervical cancer to become the most common cancer among females in India, and that's true in both urban and rural areas. That's a pretty significant shift from just a few decades ago.
That is a huge shift. So, okay, what does a comprehensive prevention and control strategy for cancer look like then, given these huge numbers and the shifting trends?
Well, it has to be multi-pronged, doesn't it? The National Cancer Control Program, the NCCP, is a key player. It focuses on prevention, early diagnosis, and treatment across the nation. We also have the National Cancer Registry Program, managed by ICMR, which provides absolutely vital data.
Right, the data is key.
Exactly. That data is crucial for epidemiological investigations, for understanding regional differences, and maybe most importantly, for modifying and improving these programs over time based on what's actually happening.
So beyond just avoiding tobacco, which we know is enormous, what are some of the other key primary prevention measures that our sources highlight? What can actually be done?
Okay, so beyond strong tobacco and alcohol control, and that involves a whole spectrum of actions, right? Education, legislation, tax increases, cessation programs. Primary prevention also includes things like improving personal hygiene, which is especially relevant for cervical cancer, lessening radiation exposure like unnecessary x-rays, reducing occupational exposure to known carcinogens, and immunization is critical. The hepatitis B vaccine for liver cancer and the human papillomavirus, or HPV, vaccine for cervical cancer.
So it's not just about avoiding bad stuff, but actively doing things to protect yourself, like getting vaccinated.
Precisely. Other measures include rigorously testing foods, drugs, cosmetics for carcinogens, controlling air pollution, and treating precancerous changes in tissues.
What kind of changes?
Things like certain cervical changes or intestinal polyps, warts, chronic gastritis. Treating those before they potentially develop into full-blown cancer. Legislation to control environmental carcinogens is also essential. And crucially, widespread cancer education, especially targeted at high-risk groups, to motivate people towards early diagnosis and treatment.
Okay. Now let's move to secondary prevention. This is about halting the disease once it's started, but before it progresses too far, right?
Yes, exactly. The aim of secondary prevention is really to halt the disease progress at an early, often incipient, stage and prevent complications. The key interventions here are early diagnosis and adequate treatment. Cancer registration, both hospital-based and population-based, is essential here too. It helps assess the magnitude of the problem, plan services effectively. But the most important part of secondary prevention is the early detection of cases. Primarily, this is done through systematic cancer screening, aiming to find it at a pre-invasive or pre-malignant stage. And, of course, prompt effective treatment following that early detection is absolutely critical for success. You have to act on what you find.
So if we connect this to the broader control measures, how does all this weave together into a comprehensive national picture? What does that look like on the ground?
It's designed as a truly comprehensive approach. It encompasses prevention, detection, diagnosis, treatment, aftercare, and rehabilitation. The overarching goal is pretty clear: reduce the number of new cases, increase cure rates, and minimize long-term disability or invalidism under the NCCP, which is now integrated with the broader NPC-DCS program.
That's the one for cancer, diabetes, cardiovascular diseases, and stroke.
Exactly. Under that umbrella, there are schemes providing financial assistance to voluntary organizations. There are district cancer control schemes focusing on health education, early detection, palliative treatment at the local level. There's also investment in specialized facilities, things like cobalt therapy installations, developing oncology wings in government hospitals, plus strengthening existing facilities for palliative care.
And how does the NPC-DCS specifically contribute to this whole fight?
Well, the NPC-DCS reinforces this comprehensive approach in several ways. It promotes healthy lifestyles through mass health education. It facilitates opportunistic screening for individuals aged 30 and above. It establishes NCD clinics at the community health center and district levels. It focuses on capacity building and training for healthcare workers and ensures rehabilitative care is available. It's truly a multi-layered, interconnected strategy aiming to tackle these diseases from many angles.
That brings us nicely to a powerful and I think often misunderstood tool in public health: screening and early detection. You mentioned it helps uncover the hidden iceberg. What exactly does that mean for someone listening right now?
Yeah, it's a good analogy. Screening is essentially an active search. You're looking for unrecognized disease or defects in people who seem perfectly healthy, using tests that can be applied pretty quickly. The hidden portion of the iceberg refers to those subclinical or asymptomatic cases, people who have a disease but don't yet show any symptoms. It's like looking for trouble before it announces itself.
So the core purpose is just to catch things before they become a full-blown clinical problem, maybe even before symptoms appear.
Precisely. The advantages are really clear. It allows for early diagnosis and prompt treatment that dramatically improves prognosis, significantly increases survival rates, and gains what we call lead time.
Lead time.
Yeah, lead time. It means we might find the cancer, say, a year or two before symptoms would have even appeared clinically. That gives us crucial time to intervene effectively, often when treatment is most successful. Screening also helps us understand the natural history of a disease, its preclinical stages, and importantly, it helps educate the public about self-diagnosis, what to look out for.
And why is cancer screening specifically so effective for many types of cancer?
It's effective for several key reasons. First, many malignancies are preceded by a pre-malignant or in situ lesion. That means the cancer cells are still contained, they haven't spread yet. These can often be removed completely.
Okay.
Second, most cancers actually begin as localized lesions, and when they're localized, high cure rates are genuinely achievable. And finally, a significant portion of cancers, maybe up to 75%, occur in body sites that are accessible for screening. Think skin, cervix, breast, mouth. This makes the test practical and impactful.
That's actually good news. It offers a real window of opportunity. So what are some of the most effective screening programs available that our sources highlighted?
Well, for cervical cancer, we have the Pap smear, which is a cytology screening method looking at cells. For breast cancer, effective methods include mammography and regular breast self-examination. And for oral cancer, cell screening or assisted screening techniques can be incredibly effective at picking things up early.
Now, I've often heard discussions about mass screening versus selective screening. What's the difference, and which approach tends to be, more fruitful?
That's a good question. The sources generally indicate that selective screening, where you target high-risk groups, is often more fruitful and resource efficient than trying to screen the entire general population, which is mass screening. However, it's worth noting that in India, there's a strong proposal or policy push for routine universal screening for oral, breast, and cervical cancer for everyone aged 30 years and above. So that reflects a desire for broader coverage, despite the resource implications.
Okay, let's maybe use cervical cancer as a powerful case study. Given its prevalence and how comprehensively it's addressed in public health strategies, what's the sort of global approach to prevention and control here?
Yeah, it's a good example. The Global Strategy for Cervical Cancer recommends a really comprehensive approach across the entire life course. For primary prevention, the main tool is HPV vaccination for girls aged 9 to 14 years, ideally before they become sexually active. But it's incredibly important to stress, vaccination does not replace the need for screening later in life.
Right. So even if you're vaccinated, screening remains absolutely crucial for ongoing protection.
That's exactly right. So for secondary prevention, screening using the Pap smear is widely recommended. Current policy in many places, including recommendations relevant to India, suggests women have a Pap test starting around age 30 and then perhaps every 3 years after that. For women living with HIV, screening is often recommended earlier, maybe from 25 years of age, and potentially more frequently. We've seen in developed countries that organized, population-based screening programs have led to really significant reductions in both incidence and mortality from cervical cancer. It works.
And for those women who unfortunately do develop cervical cancer, how is that then addressed?
So that falls under tertiary prevention. That involves providing comprehensive treatment surgery, radiotherapy, chemotherapy as needed, and also crucial palliative care for those with advanced disease. The overall strategy, as outlined in the sources, it's truly multidisciplinary. Community education, social mobilization to encourage participation in vaccination and screening, the vaccination efforts themselves, widespread screening, effective treatment options, and compassionate palliative care.
Got it. So what are the key risk factors for cervical cancer that people, especially women, should be aware of?
Okay, several important ones. Age is a factor. Incidence increases quite rapidly from age 25 up to about 45 years. Having genital warts, either past or present, is also an important risk factor. Marital status and sexual activity patterns play a clear role. It's more common in women who are widowed, divorced, or separated, and those with multiple sexual partners. It's very closely linked to sexual intercourse itself. Things like early marriage, starting intercourse early childbearing, and having many children are all associated with increased risk.
Are there any other factors that might surprise our listeners?
Yes, possibly. Oral contraceptive pills, OCPs. There seems to be an increased risk linked to how long you use the pill, especially with older types of OCPs that were high in estrogen. Socioeconomic class is also a factor. It's more common in lower socioeconomic groups. This likely reflects things like poor genital hygiene practices, maybe less access to healthcare and screening services, and fundamentally, the human papillomavirus, HPV, that is considered the chief suspect, the main cause of cervical cancer, which really underscores why vaccination and screening are so vital.
That's a lot of really important information, but it brings us to a very actionable point for you, our listener. Knowing the early warning signs of cancer. This really empowers you to be aware of your own body and, crucially, to take prompt action if something seems off.
Exactly. Cancer organizations worldwide strongly recommend public awareness of these danger signals. Now, they're not always definitive signs of cancer, let's be clear, but they are crucial indicators that absolutely warrant a visit to your doctor for further investigation. It's all about proactive vigilance.
Okay, so what are these crucial warning signs that we should all be looking out for in ourselves or loved ones?
Okay, the key ones highlighted are a persistent lump or hard area in the breast, any sudden change in a wart or mole you've had for a while, a persistent change in digestive and bowel habits like new or worsening constipation or diarrhea or any unexplained bleeding, a persistent cough or hoarseness that just doesn't go away. For women, excessive blood loss during the monthly period or any bleeding between periods. Also, any unexplained blood loss from any natural opening of the body. A swelling or a sore, maybe in the mouth or on the skin, that just does not heal. And finally, unexplained significant weight loss when you're not trying to lose weight.
Those are really vital signs to remember. And, well, that brings us towards the end of our deep dive today. We've journeyed through the hidden preventable aspects of rheumatic heart disease, which was fascinating. We've dug into the immense scale and the profound societal links of cancer in India. And we explored the crucial role of multifaceted prevention, comprehensive control programs, and critically personal awareness, especially through screening and recognizing those early warning signs.
Yeah, and what's truly fascinating here, I think, and what the sources make abundantly clear, is this profound, really undeniable connection between public health, those social determinants we talked about, and also individual agency, what people can do themselves.
Yeah.
While medical interventions are absolutely vital and they save countless lives, the overall holistic health of a population is just so deeply intertwined with its living standards, its access to education, its fundamental access to basic services.
Right. So this isn't just about treating illness once it appears, is it? It's much bigger. It's about understanding and actively creating environments where wellness can actually thrive for everyone. So maybe the final thought to leave you with is, What does this broader perspective mean for how we think about health, not just for ourselves individually, but how we approach it as a society?
It's a powerful question, I think, worth pondering.